Dr. Linda Resar is an associate professor of medicine, oncology, and pediatrics. She is a hematology consultant for the Center of Bloodless Medicine at Johns Hopkins. Dr. Resar has more than 25 years of experience in blood disorders, including anemia, bone marrow failure, sickle cell disease, thalassemia, and thrombocytopenias. Dr. Resar completed her training in pediatrics and fellowship in hematology oncology at the Johns Hopkins Hospital and Johns Hopkins University School of Medicine. She is board certified in hematology and oncology with the American Board of Pediatrics. Her topic today is progress and success on bloodless medicine strategies at Johns Hopkins. Dr. Resar.
Thank you, Andy. And I have a hard act to follow. That was a wonderful talk by Isha. So thank you all really for your interest and support. The reason we have our team, which as you've heard about really has been a wonderful group of professionals who are caring for you, is because of you. So thank you for your support and thank you for your interest in coming today. So as you heard from Andy and Steve, my job is to build up your blood and keep your blood at a healthy level. So what I do for our team is to diagnose and treat anemia and also to help your doctors minimize how much blood is being drawn. Okay, and so we've been talking about anemia all afternoon. Let's just make sure we're all on the same page. What exactly does that mean? Anemia, interestingly, comes from a Greek word, anhema, which actually means without blood. And so it's a deficiency of our red blood cells and or our hemoglobin. Usually those two things go together, but not always. And when we're diagnosing anemia, oftentimes I'll actually look at your blood under a microscope. And if you do not have anemia, let's see if, I don't know if my pointer will work. On the left, you see lots of red blood cells. If you do, there are fewer. And this is, of course, just a cartoon, but here's the real deal. So on the left there, those red blood cells, that's actually a normal blood smear from somebody with a normal level of hemoglobin. They look like donuts, actually. And if you look on the right, you see how pale they are? Some of them actually look like little pink ghosts. So that's somebody with very severe iron deficiency. And if you were buying a donut, you certainly wouldn't want to pick one of those, right? So they're pale, they're lacking in hemoglobin, and the number of red cells is lower. Okay, and so how do we diagnose anemia? How do we actually measure this? We measure both a hematocrit, so you may have heard your doctor telling you that your hematocrit is too low, and we also measure a hemoglobin. So the hematocrit is actually a fraction of the packed red blood cells to your total blood volume, and I'll sort of show you a picture that demonstrates that. The hemoglobin is actually a color assay. It's a colorimetric test that tells us how much hemoglobin is there. And hemoglobin is what makes our blood red, and it's actually the protein that carries the oxygen to all of our organs, including our heart and our brain, as you heard about from Isha's talk, our muscles, really all of the organs of our body need oxygen. Okay, so here's somebody's hand that's pale, and you can see on the side of that hand, that shows you a hematocrit. So a normal hematocrit for a male is about 40 to 50, for female is about 38 to 40, and those are for adults. And you see this person's hematocrit is down in between 2 and 3. So they're like 20 to 30%, very anemic. Their hands are pale, and with iron deficiency anemia, you can actually get very flattened nail beds as well. Anemia has been around a long time. If you go back into art, you can see people who are also anemic. And it can be hard to diagnose. Here are two adorable little children. One's a patient of mine and one is a sibling. And actually the little boy on your, I guess your left, has pretty severe anemia. You can see when you look at his lips and his gums, they're pretty pale. When you look at his sister, in contrast, she's got really rosy lips and gums in her tongue. And so it can be challenging to diagnose, and that's why we use a hematocrit and the hemoglobin, and we very carefully examine our patients. And why do we care? Why do we need our red blood cells? As I mentioned a bit earlier, all of the organs in our body need oxygen. So the purpose of a red cell, it's basically a sack of hemoglobin that's delivering oxygen to our hearts, to our brains, to all of our organs, and that's vitally important. And so when you come to our team, our first question, at least mine, is what's the hemoglobin? And so what we like to do is figure out if you do have anemia, if your level is too low, and then we want to treat it. So when we're figuring out what's the best therapy for you, the first question is there any nutritional deficiency that we could replace to help you build up blood? You've heard a little bit about iron from Liz's wonderful movie. That's a very common cause of anemia. Globally, it's the most common cause of anemia. Sometimes we see patients with B12 or folate deficiencies. We've had some patients with those on our Bloodless team. They're less common, but they do occur. Many patients, as they get older, their kidney function declines. And in particular, people who have diabetes are at risk for declining kidney function. So when your kidneys don't work, you don't make enough of your own EPO hormone, so you can get anemic. And then patients with other comorbidities, even things like obesity or diabetes, that alone can cause anemia. So the first thing that I do when I'm looking at our patients is to figure out what is their cause. We also have lots of patients with hemoglobinopathies like sickle cell or thalassemia, and we need to know about that as well because patients with sickle cell who have anemia aren't going to respond to iron, and so we really need to know what is the cause for the anemia. And the third thing we like to do, particularly for patients who are going to surgery, is to find out if they have what's called a bleeding diathesis. There are common disorders that cause patients to bleed extra, to bruise easily, to get nosebleeds, or for women to have heavy menstrual periods. They're quite common. There's something called von Willebrand disease, and it occurs in about 1 in 100. So it's possible that 1 or 2 of us here has that. When we diagnose it, we can use effective medicines to prevent bleeding. And so that's another key tenet in our evaluation of patients. So how do we treat anemia? You heard from Liz, there are foods, and even though Popeye used to tell us that spinach has a lot of iron, it actually doesn't have a huge amount. Things like red meat and fish do, and oftentimes we use oral iron. And you also heard some about EPO, and you might recognize that guy, Lance Armstrong. As Steve mentioned, he used, and a lot of actually runners and bikers used EPO to build up their blood. And EPO is a hormone, a natural hormone, we all have it. It's made in our kidneys, and that's why patients who have kidney disease very often have anemia. And what it does is it goes to our bone marrow, and here's a picture there. Bone marrow is actually in the middle of our long bones, in the middle of our skull bones. That's where our blood's made. And it goes to the precursor cells. They're sort of the parents of the red cells, and those are the big purple guys. That's where the EPO is working. It's telling those cells to make red cells. And so that's why we occasionally will use EPO to help get our patients ready for surgery. We like to personalize their therapy. So you heard a little bit about the kinds of iron you can get as an outpatient. We also have a clinic, and many of our patients who are coming for surgery or who are anemic and just not feeling well because of the anemia, we treat them. And we take a very personalized approach. For patients who have mild anemia and can tolerate oral intake of iron or can change their diet, that works, and that's great. Some patients are really severely iron deficient, so we have to give them large doses of IV iron. And there are different preparations. Sometimes in the hospital, we have patients who have mild anemia. They're not really iron deficient, but we want to build up their ability to build blood to get them ready for surgery. We might give them a low dose of iron together with EPO. So these are some of the different iron preparations that we use in our clinic and in the hospital. EPO, too, we like to personalize for you. So if a patient has mild anemia, we need to build up their blood to get them to surgery. We have 2 or 3 weeks. We might just use the subcutaneous variety. It's a shot that a patient could get 2 or 3 times a week or just once a week. And again, we personalize it. How soon is the surgery? How severe is the anemia? What are the other things going on? Patients, for instance, with kidney disease will often give more and higher doses. And many patients with kidney disease are on this as part of their routine care. In the hospital, we like to give IV EPO because it works very fast, and it's in and out of your system quickly too. So for patients who do have side effects, we mitigate some of those side effects. And there's another variety called darbepoetin. It's conjugated with a glue-like substance that causes a slow release, and some of our patients get that as well. When we started our Bloodless program, there really were not many published studies to tell us how to do this. And one of the studies that we followed was published at Penn, and I think we've gone many steps further than what they've published. They talked about using EPO and getting the hemoglobin up, and we've been able to come up with very specific protocols and personalized therapy for our patients. And in fact, one of my most recent patients drives all the way from Philadelphia to come here because she feels that we're able to give her better care for her anemia. And this is, we like to show numbers. How are we doing? This shows some of our patients, and actually this is much better now because this goes up only till about December when I gave that presentation in San Francisco. But our patients are coming in before surgery, and this is mostly heart surgery, so we are shooting for hemoglobins of around 13. And you can see all of our patients got to that level where our therapy's been very effective. And this actually I like to show because it's another example of personalized therapy. And I know some of you had questions about iron, about EPO. This shows you a little bit about how we tailor and personalize the therapy to each patient. This was a patient of ours, very sweet woman who was a very conscientious employee. She didn't want to miss work. She was very severely anemic. I don't know if you can see this, but her hemoglobin was 5.9. And so as soon as we saw her hemoglobin, we started her on oral iron. We knew she wasn't feeling as good as she could because her blood level was so low. So we had her come in for IV iron, and we had her come in for a few more doses. The cause of her bleeding was uterine fibroids, and so we knew that this was going to be ongoing loss. Each ml of blood actually has a milligram of iron, so when you lose blood, you lose iron. So we've given her now 3 doses. Because she's a very conscientious employee, she doesn't like to take off from work. We've been able to work it out so that she comes in between 7 and 7:30. We give her an infusion. She feels much better and goes off to work. And we've gotten her to improve the hemoglobin a lot. She feels better, and now we're working with the best surgeon we can find to help treat the uterine fibroids. So that's just an example. Here's a patient who just had iron deficiency, so we didn't need to go to EPO. And her kidneys were working perfectly well as well. So that's a nice story. Now somebody asked, what about a car accident? What about acute bleeding? Well, you all know iron and EPO take some time. So actually this past year, we were able to open up a protocol where we have an agent called sanguinate. And it's this particular hemoglobin substitute comes from cows that are raised just for this purpose. We take the bovine or the cow hemoglobin and conjugate it to carbon monoxide, carboxy, hemoglobin it's called, and it's also pegylated, so it's mixed with a glue-like substance like darbepoetin, so it's a slow release. And this has been used safely in patients. It's not been used in a large number of patients, but it's been used safely in patients who cannot accept blood transfusions with success. And just to give you a little vignette of who we might consider it for. I don't know if you remember the snowstorm early in March. Everything was threatened to be shut down, and it did, the airport and all the institutions. We had a patient coming in with a bad GI bleed. His hemoglobin was about 5, and we weren't sure if he was going to stop bleeding. So that's sort of like the car accident scenario. So we met him. He had talked to Andy and Isha before arriving. We made sure that we gave him iron because with all the bleeding, he was iron deficient. We gave him EPO, and we had a special shipment of sanguinate arrived in our blood bank at midnight. Snow had started, but it wasn't up to a foot or two yet. So fortunately, he did beautifully through the surgery. We were able to stop the bleeding. With just iron and EPO, he was able to get his blood to a safe range, but we had this in case we needed it. And there are even newer agents on the horizon that may be better hemoglobin substitutes. So we're always looking to see what's available, what's best, what's been used the most. For this patient, we had a couple options, and this had been used in the most patients, so we felt that it was the safest agent available. And who knows, maybe next year we'll have something more exciting to tell you about. We've also come a long way in caring for cancer patients. Many of you, I'm sure everybody here knows somebody who's had cancer, and cancer therapy tends to be really harsh therapy that can shut down blood cell production. Well, we work together with our oncologists to develop personalized therapy so that you're getting chemotherapy that isn't going to shut off your blood cell production. For instance, we've actually cared for 3 patients successfully this past year with lung cancer. And instead of using cisplatin, which is a chemotherapeutic agent that really lowers your blood counts, we personalize it and use carboplatin, which is much less suppressant to your blood cell production. And we've gotten 3 patients through their therapy who've done really well with this. Another cancer that we've had some experience with over the last year is lymphoma. You might know it's a blood cancer that involves the lymph nodes. And for these patients, we've used standard therapy with EPO, and they've done well as well. So we're working to find new agents that will not suppress blood cell production. And lastly, I just want to close by thanking you all. This is a family that I've known for almost 2 decades. I cared for their little girl there on the right for a number of years. She actually had low platelet counts, and we used a medicine to raise her platelets. Unfortunately, she died about a year ago in a car accident. Her mom in the middle, this year, about 2 weeks ago, just underwent a very successful cancer surgery. She was anemic, and we treated her with iron to get her to the surgery. We didn't use EPO because there are some cancers that will grow when exposed to EPO, so we avoided it. And that's just an example of how we personalize your care. And so I think we made a lot of progress. We weren't able to tell you about lots of these interventions last year, and we're planning to just push ahead and continue to improve our therapies. We want to develop the best approaches to increase your blood production, even white cells and platelets, and we also want to develop new cancer therapies. And we actually are testing different agents in the laboratory to treat cancer cells that may not suppress blood cell production. And let's see. We also want to provide the best care for our patients, and I can't resist showing you beautiful pictures. We can't take credit for how beautiful our patients are, but you can see that's certainly true. They come in all ages. As you heard from Dr. Frank, we care for moms having babies, and it's always fun to watch the babies grow up. And I think she has her parents to thank for why she's so beautiful. And the other thing, actually, we're also teaching student doctors. Actually, this summer I have a student doctor from Saudi Arabia. Last year I had a student doctor from India. Dr. Frank has lots of student doctors in his group. We're trying to teach them the principles of bloodless medicine and how they can care for patients in their part of the world. So lastly, I just want to close with a very special thanks to all of you. Some of you who were here last year saw this picture, another patient that we cared for who delivered a healthy baby. So any questions?
You mentioned a product called Sangunate. Is that the same or similar to the product that was out a few years ago, Hemopure?
Yeah, so there are a number of hemoglobin substitutes. I think Sanguinate is a different one, but they're similar. These are hemoglobin substitutes. Some of them are completely synthetic, some of them are bovine derived. And it's a technology where there is quite a bit of active research. So we're going to be meeting with another company to look at another agent. And I guess when I'm trying to figure out, well, what's the best thing for my patient, I look at how many people have been treated, what are the side effects, and can we get it? And in this particular case, this was the agent that's been used the most with the biggest experience that we were able to get that night.
So is this Sangunate available in most hospitals?
No, it's not. Right, and it's actually compassionate use. We had to call the FDA to get a compassionate plea approval. And many of these companies who are developing these new agents feel comfortable only in a large tertiary care center where they know that the patients are going to be getting the best care and that they are going to be very carefully monitoring the status of the patient. So they're not really widely available at some of the smaller hospitals.
But the question is related to what you mentioned about examples of cancers that will grow if you use EPO.
Right. So there are a number of cancers that can have EPO receptors. And for instance, in some breast cancers, we can see EPO receptors. In some, even colon cancers, we can see EPO receptors. In kidney cancers in particular are often associated with EPO receptors. So for our patients who have cancers where they might grow with EPO, we try to stay away from it. And again, we work very hard to personalize our therapy. It depends on the age of the patient, whether the cancer has spread, if the cancer, some of our patients come to us with a very curable disease, and in that case, we try to avoid it, even if it's not a tumor that's associated with EPO receptors. We try to take the absolute safest approach. Sometimes we see patients who are elderly and have widespread cancer, and in that case, our therapy is only palliative. So for a patient like that who is doing well without blood, we might say, well, we know there's a small risk, but we want to do everything we can to get you feeling better and to keep you feeling well. In that kind of a scenario, the goal for the patient is to keep them feeling well and comfortable. And so in that case, we might use it. So again, we very much try to tailor it to each individual situation. If a patient has a chance for a cure, we try to avoid it. If a patient's receiving palliative care, we see how it goes. And we take a middle approach for patients who are in between that spectrum.
Just to repeat on the last one, besides kidneys, what other organs have EPO receptors?
Oh, well, so the kidneys have EPO receptors, and they that's the organ that synthesizes EPO. And then what happens is when you're anemic or you're at low oxygen levels, that's why some athletes go to high altitudes to train, or if you go to Mount Everest, you actually come back with a higher hemoglobin. So what happens is your kidneys sense low oxygen. They secrete, first they generate the hormone EPO and secrete it, and it goes to the bone marrow. So the cells that have the most EPO receptors are those red cell precursors I showed you in that picture of the bone marrow, the big purple ones. And what the hormone tells those cells to do is to make more red cells. So that's why we have EPO receptors. There aren't a lot of EPO receptors on other organs. Sometimes tumors have them, though, and that's sort of an abnormal expression of that protein.
And the other question is, with bloodless alternatives, what's the standard sickle cell treatment?
Okay, so that's a really good question. We have a number of patients with sickle cell, and so in those patients, interestingly, one of the little patients that I showed you in the picture, he has sickle cell. So he's born and used to a hemoglobin of 6 or 7. So we individualize therapy for them. First, we need to know that they have it, and then we know that at 6 or 7, that's normal for him. So we wouldn't want to transfuse him. If he went to another hospital that wasn't experienced in sickle cell, they might transfuse him. We try to optimize our sickle cell patients' management without blood. And in fact, one of the patients in whom sanguinate was used successfully was a sickle cell patient. So I think there are becoming more options for our patients with hemoglobinopathies. The most important thing is to recognize it and know how to treat it.
My husband has only one kidney, and it is diseased. I don't know how bad it is. He goes to a kidney specialist, a Good Samaritan, but recently he had blood work, and the medical doctor told him his hemoglobin was low, and that he does have kidney disease. So he seemed more concerned about it than the kidney doctor. What would you recommend?
Well, so again, it depends on the level. And as Dr. Frank mentioned, there have been some bad side effects in kidney patients who've gotten their levels up above 10 or 11. So usually we work closely with the kidney doctors, and if there's a surgery needed, to find out if EPO is needed and how much EPO is needed. When we're starting EPO in a patient who's anemic and has kidney disease, we usually start with low dose IV many times a week. When our patients are on dialysis, we try to give it IV when they get dialysis. But it's not unusual for a patient with kidney disease to become anemic. And so what I would recommend is for your husband to see a good kidney doctor who can help decide if EPO is needed and how much is needed. And of course, we're always available to help and to consult, and happy to do so.
Thank you.
You're welcome.